Hello everybody, my name is Eric Ullman. I am a physical therapist. I work at Landmark. I've been in PT since 2002. Today's talk, I'm going to kind of go through some PowerPoint. I'll elaborate on some of the points. If there's questions that come up along the way, just raise your hand. I'll definitely leave some time at the end for questions as well. So throughout my career, there's been a lot of things that I've enjoyed treating. And I would definitely put headaches at the top of that list. To have patients come in where they have this debilitating pain they've had for days, weeks, months, years, pain that goes in the base of the skull, into the eyes, side of the head, into the jaw, and for us to be able to make a difference and reduce it, even more so to get rid of it entirely is incredibly rewarding for us as the clinician, and of course the patient as well. So I find it's kind of fun to treat. Everybody's a little different. As physical therapists, we have to look at everybody as a whole. I'll go through our evaluation and how we go about assessing our headache patients, but today's lecture will be, I'm going to focus on some of the more what we call cervicogenic headaches, which are the headaches that come from the spine. I will touch on some of the other kinds of headaches as well. I don't want to get in too much detail as far as the other headaches. It's not my area of expertise, but we will touch on that. All right. I can figure out how to operate this though. Working? Yeah, it's not working now. All right, we'll go from here. I really wanted to use the remote, but guess I'm not doing that. All right, objectives today, what you'll learn. First off, the 3 most common symptoms physical therapy can help. So we'll try to teach you, educate you on symptoms that can come up where you say, you know what, this might be a time where I go see a physical therapist. Number 2, the differences between what we call musculoskeletal or cervicogenic headaches. So we're going to use those 2 terms interchangeably versus other kinds of headaches. Lastly, 3 easy drug-free treatments you can use to diminish a headache. So first off, what is a cervicogenic headache? So, as we said, cervicogenic headache, also known as a musculoskeletal headache, is head and or neck pain that is referred from bony areas or soft tissues of the neck, including the muscles or joints. So I'm sure you guys have seen the pictures of anatomy, all these muscles that we have running through our neck. And when I say the neck, I'm kind of talking about from the mid back up. We have joints, we have nerves, we have muscles, we have all these nerves that exit through here, we have the area around the skull. All those areas can refer. A referred pain is pain that is felt at a site other than where the cause of the pain is located. So the example, I know this is an extreme example everybody knows is a heart attack. Pain goes down the arm, there's nothing wrong with the arm, that's a referral. So these kinds of headaches can occur on their own or in conjunction with other types of headaches, especially migraines. So I think most people in this room have heard of migraines. So we're going to talk about the role that we can play as PTs with migraines. We're not treating the migraine directly, but we can talk about how that's going to interact with the migraine. Causes of cervicogenic headaches. So 2 major things. We see traumas, such as a motor vehicle accident, or fall, or an assault. So with motor vehicle accidents, we typically see the whiplash type of injury, the coupe, counter coupe, head goes forward and back. A fall, someone falls, they hit their head, leads to headaches. An assault, someone's hit with a baseball bat, or someone comes up, grabs them, that can lead to headaches as well. The other side is the sedentary lifestyle. So this is the majority of our patients. I call computers the blessings and curses. So these are the people that sit at desks all day, which is the majority of us. As we sit, the more we sit, the more of what we call adaptive shortening and faulty mechanics develop in the neck and what we call the upper quarters into the shoulder as well. So some of the headache types. Again, I'm going to name just a few. I just want to elaborate on, kind of make some key points with some of these headaches, but I really don't want to get into too much detail as far as these other kinds of headaches. So first off, the migraine. Migraines can be inherited. They're diagnosed by at least 5 episodes of headaches, each lasting 4 to 72 hours. Meets at least one of the following, including nausea, vomiting, sensitivity to light and sound. Also, 2 of the 4 criteria, including one-sided pain, so we'll have pain on one side of the face, throbbing pain, moderate to severe pain, or pain that worsens or interferes with regular activities. Next type, sinus headaches. This is a type of headache I know very well, especially in the springtime. Inflammation of the sinuses leads to headaches. Other symptoms as well leads to sinus infections. Often comes with a fever. Treatment for those is antibiotics, antihistamines, and decongestants. Cluster headaches. These are headaches that most commonly affect men more than women. These can be genetic. They usually appear suddenly and usually in groups or cycles. Severe pain, usually on one side of the face, often includes a runny nose or watery eye just on one side of the face. Often people feel restless or uncomfortable, and there's no cure, although medications can provide relief. Rebound headaches. So these are caused by an overuse of painkillers like Tylenol, ibuprofen, Motrin, aspirin. There's 2 theories with these. One is that there's too much medication that causes the brain to shift to an excited state. The other theory is that it's a symptom of withdrawal as the medication levels decrease. So, how many different types of headaches are there? Depending on who you talk to, some neurologists will say there's up to 150 different types of headaches. Okay? Many are hard to tell apart, and obviously there's overlap. It's not, the way the body works, it doesn't work where everything's nice and organized, and if you have this, you only have this. There's a lot of these headaches that can present very similarly to other types of headaches as well. So one person can experience more than one type of headache. Most commonly, as a physical therapist, we see people with obviously the cervicogenic headaches in addition to migraines, sinus headaches, depending on the time of year, or other types of headaches as well. The headaches can play off of each other. So we see this a lot where the cervicogenic headaches makes the migraine headache worse, and the migraine headache makes the cervicogenic headache worse. So the cervicogenic headaches, as I mentioned, they can appear in conjunction with other types of headaches, such as migraines, and as I mentioned, they can kind of play off of each other and make each other worse. So, some of the symptoms that physical therapists can help with. So pain that is localized to the base, side, or front of the skull. So the base of the skull, we call it the suboccipital or occipital area. The side, the temporal or parietal area, or the front, the frontal lobe. Pain that is localized above or behind the eye. So we call this supraorbital and retroorbital. I've seen many people over the years, I've actually experienced a couple of these myself a while back, where horrible pain, feels like a knife is pushing from behind your eye. Typically, unfortunately, we see these people at the end, after they've gone to the ER and the neurologist and the ear, nose, and throat doctor. We would like to see those people earlier on. But typically they come in, they don't know what to do, they've gone to everybody, no one knows what's going on, and these are the people we do very well with. Also, jaw and ear pain. So I get a lot of patients that come from dentists. They say, oh, I think they have something wrong with their jaw or their TMJ. And it turns out it's a cervicogenic headache. Pain that's into the head or neck that's intermittent. So it happens here and there and lasts from hours to days. Also, pain that worsens with head or neck movements or sustained or awkward positions or range of motion is often limited. So typically with the insidious onset, I'll have patients come in, no history of any neck issues, and they'll say, I don't know what happened. I went out to dinner with some friends and I was sitting across the table, or they were sitting on their couch looking at the TV in an awkward fashion. Next day, a horrible headache. So the biggest thing we see is sitting at the desk, at the computer. We're going to talk a little bit about how to adjust your computer and how to adjust your seat accordingly so that you're not causing stress to those tissues around your head and neck. Also, any of these symptoms can be with nausea or visual disturbances. So these are some of the referral patterns. We can see here in A, some of the areas into the suboccipital and the neck, around the eye, above the eye, and into the jaw. Where it's more concentrated is where we typically see more of the focus of the pain. You can see in the second one over here, there's spots that go typically in the upper trap, can refer into the frontal lobe in there. As you see, some of them are more on one side than the other, or only on one side. These are just a few referral patterns. There's obviously many more.
What about a referral pattern? What's that mean?
So referral patterns, so I mentioned earlier, here we go. Show you this right here. So bullet point number 2 over there. And so that is basically pain that is felt at a site that's other than the actual site.
Where the X is where the problem is, and the red is where the pain was.
So this, actually, you see those letters TP, they're talking about trigger points in there. I'm not going to get into trigger points. So where the X is, they're talking about trigger point injections, actually.
Okay.
So I was looking for a good picture, and they got into some of that. Good question. But that is where you would do an injection into the muscle. We do not do those, so I'm not going to get into those. Okay, so diminishing your headache. Big thing is check your posture. So very general pieces of advice: sitting up tall, pulling the shoulder blades back, standing up every 30 minutes. So my patients that sit at desks all day, I set goals where I say you'll be able to work an 8-hour shift sitting at your desk, standing up every 30 minutes. Okay, doesn't mean you stand up for a while, you just stand up for a few seconds to get out of that seated position. As I said, as we sit, we start to develop this. A lot of people, I see a few people in this room with glasses. That unfortunately makes it even worse. Bifocals even worse. Try to adjust to read the computer with their glasses. That can lead to headaches. Self-massage or general massage, so anywhere from the suboccipital all the way down to the mid-back. And we'll talk about some of those areas here in a second. Some exercises, we can try these right now. We can make this a little bit interactive. So chin tucks. We sit up nice and tall. The chin tuck is where you make the kind of the double chin. Push your head back. There's 2 places you might feel that. One is in the neck here. The other one's in the base of the skull. So the muscles we're working here are the muscles that get your head more from a forward position to an upright position. These are the deep neck flexor muscles, okay? The sensation, if you feel it in the base of the skull, that's usually a stretching sensation, stretching the muscles of the base of the skull. With my patients, I have them do it for about 5 seconds and do them maybe 9 or 10 times. Great reminder for these is do them, whenever you come to a red light. Okay, it's a good reminder. We're all driving, we hit traffic, we get red lights. I like my patients also trying these at home, lying on their back as well, so you get a feel for doing these in different positions. Neck stretches. So some of the key muscles that run from the neck onto the collarbone and the first and second rib. What we do on these, if we sit up nice and tall, you guys can move to the edge of your chairs, move forward a little bit, grab on with one side, with one hand, grab onto the leg of the chair with one hand, and then tilt your head the opposite way. This looks really funny looking at you guys right now. Okay, you should feel a nice stretch on the side that the anchor arm is on. When you go the other way, you'll get the opposite side. So you want to make sure that when you do this, you're sitting up nice and tall. Often I'll encourage my patients to almost do a chin tuck first. I had a patient this afternoon who's coming in for actually some TMJ as well, and headaches. And I had her do these stretches, and she kept going forward like this. So I had her sit up nice and tall, do a little bit of a chin tuck, then go to the side. These, I like 30 seconds twice. Nice thing about these is you can do them anywhere. You don't need any equipment. Okay, next one is rows. So in the first picture here, we have arrows pointing to the inside of the shoulder blade. What we're working here are the muscles that retract or pull the shoulder blades back. So as a simple exercise without equipment, you can sit up or stand up and just pull your shoulder blades back like you're rowing a boat. This guy over here is doing some with, looks like Therantube or cable in the gym. Great exercise, pulling those muscles back and working the muscles around the shoulder blades. With these, 2 to 3 sets of 10 is good. Okay, so I want to get into the physical therapy aspect of how we look at, how we assess and treat patients with cervicogenic headaches. So, first off, we look at posture. We always look at posture first. No one has perfect posture. When we're talking about the upper half of the body, things we're looking at are forward head. Is the head neutral? Is it forward? We look at curvature of the spine. We call this a cervical lordosis. So when there's more curvature, some people are really forward. People with osteoporosis, really forward. Rounded shoulders. Do the shoulders go forward? Do they come back? Kyphosis is the rounding of the mid-back. And a flat back is where they have a lack of that. Okay? No one has perfect posture. So no matter what kind of posture you have, it's going to have certain implications on your body. So posture we look at from kind of a front view and a side. Okay, then we look at neck, mid-back, and shoulder range of motion. So to name a few, with the cervical spine, I'll demonstrate these for you guys. So we look at what we call active range of motion, which is your muscles, you making the movement. We look at forward bending, which is bringing your head down, backward bending. We look at rotation, looking to the right, looking to the left, and we look at side bending, side tilting right, side tilting left. Now, when we do that, we're looking at quantity and quality of these. We're looking to see how far they go, and obviously we expect a difference when I have a teenage patient versus a 90-something-year-old with osteoporosis and arthritis. I'm not expecting the same kind of range of motion. So looking to see, does it reproduce pain? Do they have any faulty movement patterns? Does it increase their headache? Often they're pretty straightforward. They turn to the left, that increases my headache. So from that, we get information. Next one, we look at the thoracic. The thoracic is the mid-back, the area of your mid-back where the ribs attach. So we'll look at certain motions such as backward bending, how they side bend into the thoracic, and how they rotate into the thoracic. Then in the shoulder, we look at the simple motions are lifting their arm up. So when you lift your arm, it's not just a matter of the shoulder moving. There's shoulder blades, there's the ribs are moving, the spine's moving, muscles have to have flexibility. There's a lot that's happening there. So we look at lifting up. Again, we're looking at quantity and quality. Abduction, which is lifting to the side. External and internal rotation. Then what we call functional external internal rotation, which is reaching down your head or behind our back. Okay? And again, we're looking at quantity and quality. We're noting anything, we're made to, the way we're trained is we look at all those little details that happen. When you reach behind your back, are you rolling your shoulders forward? Are you compensating? Are you elevating your scapula? So we're looking for things like that. Again, next we have muscle flexibility or muscle length. So some of the areas we'll look into the neck. Most of these, we get you on your back, what we call the supine position. We'll look at the trapezius muscles, the lats, the latissimus dorsi, the scalenes, which are the muscles that come off the rib onto the vertebrae in the neck, and the suboccipitals at the base of the skull. So we're looking for good flexibility and symmetrical flexibility on each side. Mid-back, some of the areas around the shoulder blades. So around the shoulder blades, there's different attachments of different muscles that have different directions of pull. The latissimus dorsi is one of those. That's the big muscle that attaches to the base of the shoulder blade. The middle trap and the rhomboids are the muscles that pull the shoulder blades back. Into the shoulders, we look at the rotator cuff and the pecs, just to name a few. So the rotator cuff plays a role on rotation of the shoulders. It also depresses the humerus, so pulls the shoulder down. Okay, so sometimes when we see people, it's not uncommon for neck patients to have shoulder issues and shoulder patients to have neck issues. So we look at that as well. Okay, next we look at muscle strength. Okay, into the neck. Muscles that we're looking at are the deep neck flexor muscles. So these are the muscles inside the neck. Not to be graphic, but if I was to rip away these muscles here in the front, they're the ones that attach on the front of the vertebrae. These are the ones that keep your head here versus here. Okay? Again, going back to my evaluation I had this afternoon, I had her lie on her back, tuck her chin, and try to lift her head barely off the table, and she could not do anything. So she has very poor deep neck flexor muscle strength. She should be able to lie her back, tuck her chin, and lift her head up and hold it for 10 seconds. That was not happening, but hopefully she will by the time we're done with physical therapy. The mid-back, as far as strength, we're looking at the traps, the rhomboids, and the lats, the muscles that go around the shoulder blade. Into the shoulders, we're looking at the rotator cuff, which we mentioned before. Joint mobility. So every joint in your body has a certain direction of motion that it moves. As physical therapists, we have to know every single joint in the body and how it moves, how it should move, and be able to recognize when something's not right. So key areas we look at. We look at the head and neck. So we're looking at the spinal joints, all the individual vertebrae, including the first and second rib, which we access from up here. So if you want to find your first rib, you can reach behind your collarbone and just sink straight down. There's a little So if you go from your collarbone, go back just a little bit. This is your collarbone right here. Go back just a little bit. There's a little soft spot, then it gets hard right there. That's your first rib. So those ribs should be able to move. And some of these muscles that play a role in the neck, when they're tight, they pull the rib up and they prevent it from moving properly. The other area we look at is the suboccipitals and the joints that are under there. So those are the joints at the top of the spine under the head. Into the thoracic, we look at the mobility of the thoracic spine and we look at where the ribs attach to the spine. Ribs need to move. The thoracic, that mid-back, is an area that needs to be very stable because the ribs attach there, but it also needs to be mobile. When we take a deep breath or we twist, there's movement that happens or should be happening along the ribs. And sometimes when people are stuck, especially in these kind of kyphotic positions as well, the forward head, round shoulders, they lack movement in there, and that can cause stress to the neck and therefore headaches as well. Shoulders, so we look at the mobility of the shoulder blade and the humerus bone, the arm bone. As far as the evaluation and treatment, after the assessment, things we might utilize, modalities, such as ultrasound, electric stimulation. So we use these to promote blood flow, promotes healing, and decreases inflammation. Some of the exercises, talked about the chin tucks, the rows, some of the rotator cuff muscle exercises and postural exercises. We'll talk about some of those in a second. Education, this is huge. Okay, I spend a lot of time educating. My saying is, if you don't understand it, you're not going to get it, you're not going to get better. So if you've been a patient of mine, you know I will talk a lot. I like it. You have to understand what's going on. You have to understand how to manage it. Okay? So talking about body mechanics, we talk about how to sit when you're in your car, when you're at your desk. Monitor should be at eye level. Feet should be on the floor, on a supportive surface. Arms should be on an armrest. Wrist should be on the table. In the car, I mean, I learned 10 and 2. I hear it's different now. It's not 10 and 2 on the steering wheel. What is it now?
4 and 8.
It's 4 and 8 now. I can't keep up. So, still, upright posture. Newer cars have the headrest that comes forward to prevent whiplash. Okay, we want to adjust the seat. So many people get into the car and they don't even adjust the seat. So, different size bodies, different postures. You need to adjust that seat when you get in the car.
I have a question.
Yes.
As far as how you sit in your car, is there a difference for individual bodies based on whether you like your seat further back or more straight?
Yes. So everybody, the best way I can answer that is that everybody has a neutral position. Okay, so it's not a one size fits all. Everybody has a neutral position. And some of that has to do with your structure. So for you, as a younger petite woman, I don't know why you're laughing right now. You're going to be different than, say, your husband or someone who's a foot taller than you and 100 pounds more than you. So a lot of that, it is a good question. So a lot of that comes down to your body frame, your size. So things have to be adjusted from person to person. For some people, having it back a little bit is more appropriate structurally. So it's not that everybody has to have a perfect right angle in that seat. The other thing that's big, bending, lifting. Okay, the head and neck play a big role when you bend and lift and pick things up. I see this all the time. You go to people stand up, they go from sit to stand and they jet their head forward. They go to lift something, they're bringing their head forward. Okay, so you want to be aware. It's not that you have to be in a chin tuck, but have that neutral position, have that awareness of where your head is. One of the biggest ones, sleeping. Spend a third of your life in bed. Okay, I think it's funny when I get people that come in, they spend $400 on shoes, but they don't want to spend more than $15 on a pillow. Okay? Spend a third of your life in bed. You need a good supportive pillow. There are pillows. I do like the memory foam, not for everybody. They make memory foam pillows that are made for people that sleep specifically on their side. They make them for universal positions, so any position you want. I don't like people lying on their stomach. Not a good position for your neck. But proper pillow, proper use of pillows. I often encourage my patients to bring in their pillow when we go over proper use of pillow use. Okay? It's important. And lastly, a home exercise program. Every single patient that comes into Landmark Physical Therapy gets a home exercise program. And that starts day one. No exception. Okay? Some of them are more basic than others. But everybody gets a home exercise program. At the end, you will have a home exercise program that is specific for you. We'll build up a program that counteracts everything you do. Most of our patients are not in our office because of one specific incident. They're there because of life, how they sit, how they drive, their favorite chair, their posture, their structure. So because of that, we need to give them a specific exercise program that counteracts all those negative things that they do throughout the day. So in summary, there are many different types of headaches. You can have more than one headache or more than one type of headache. Physical therapy can help with treatment and education on managing headaches. Lastly, this is a big thing. So I get people that call me and they say, I don't know if you can help me or not. And I'll say, well, come in for an evaluation. Well, I don't want to pay for an evaluation if you can't help me. So Landmark Physical Therapy does a free 15-minute screen. Call up one of our offices. Tell them that you want to do a 15-minute screen. It is free. There's no catch. You will come in. We'll do an evaluation. We'll get a brief history. There's no treatment involved, but at the end, we'll tell you what direction you should go. Okay, I will say most people end up being patients after we recommend physical therapy, but definitely had patients where I recommended you go to the doctor or you go to a neurologist. So we will triage you accordingly. Okay, and I've seen so many people take advantage of this. I think it just gives you peace of mind. No one likes to open up their wallet if they don't need to. So as I said, most of those patients do end up being physical therapy candidates, but I think it gives most people peace of mind knowing they can come in, do a screen, and we'll determine from there what's appropriate. And that is it. So I thank you. And at this time, I will take any questions.